Stratifying patients to better target treatment. What impact does this approach have on chiropractic management of back pain? There are many new approaches being piloted in an attempt to save healthcare dollars. This includes spine care. Let's review one of the most prominent models that's found its way from the UK to the US. It's called the Subgroups for Targeted Treatment, or START categorization of patients. This began in 2008 with a study to validate a questionnaire used to divide patients into risk groups based on prognosis. The StartBack program was based on the concept of triage by the healthcare provider who saw the patient first. Here it is, a primary care back pain screening tool, identifying patient subgroups for initial treatment. This was followed by several studies and finally, in 2011, led to the publication of the article we will review. Comparison of stratified primary care management for low back pain with current best practice, a randomized controlled trial by Hill et al., published in Lancet. We'll be taking a look at this study and try to discover why it became so appealing to U.S. health management companies. One of the most obvious initial confusions of why it has appeal is that this study was focused on physiotherapists, not chiropractors. Let's first try to discover the rationale that motivated the development of the StartBack approach and the subsequent study of applicability in the UK. Several evidence-based questions were being asked. Given 85% or more of back pain is nonspecific, meaning no underlying disease or pathology is identified as the source, is a healthcare provider necessary for all patients given the natural history of resolution? Given it's been shown in many studies that who a patient sees first influences spending and whether unnecessary testing is ordered, should this entry point for triage be reconsidered? And given recent research seems consistent in the observation that prognosis is more based on psychosocial factors that include fear about pain, mood, work satisfaction, etc., should these be part of initial screening and categorization of patients with referral to professionals with training in these issues? Here's a good summary of the current evidence regarding psychosocial influences. Psychosocial Influences on Low Back Pain, Disability, and Response to Treatment by Hill and Fritz, published in Physical Therapy in 2011. So where and how was this study conducted? It was conducted in England at the Keele General Practice Research Partnership from 2007 to 2008. Patients were recruited by letter from the two National Health Services centers. They were then randomized into an intervention group and a control group. Keep in mind that patients had already been seen by a primary care MD and were potentially under care at the time of recruitment. The purpose of the study? Their hypothesis was that stratification leads to better clinical and economic outcomes. Specifically, for each of three risk groups, they wanted to answer, for the low-risk group, does minimum intervention provide non-inferior clinical outcomes? For the medium-risk group, does this approach lead to better clinical outcomes compared to usual care? And for the high-risk group, does psychologically augmented physiotherapy lead to better clinical outcomes? I'll explain these risk groups in a moment. On the participants' first visit, a baseline clinical assessment and treatment session occurred. For the control group, a 30-minute physiotherapy assessment and treatment session was conducted. Advice and exercise were given, and an option of continuing on for further physiotherapy was offered. For the intervention group, a 30-minute physiotherapy assessment and treatment session was also conducted. Advice for appropriate activity, including return to work, was given. A pamphlet of local exercise and self-help groups was given, and they also watched a 15-minute educational video and were given a back book. Medium and high-risk patients were referred for further physiotherapy. So we need to stop here and ask the question, is this study what it appears to be? Is it deciding who sees the patient, or is it more about how much care they receive and if specialized care is necessary? More on that in a moment. The outcome measures? The primary outcome measure was the Roland Morris Disability Questionnaire at 12 months. Secondary outcomes included the numbers referred for further physiotherapy, back pain intensity, a pain catastrophizing scale, fear avoidance beliefs and health-related quality of life, risk subgroup reduction in pain, and the number and attendance of physiotherapy sessions. For those interested, some of the statistics were that there were 850 participants, and it was projected that there was a loss of 25% of patients to follow-up, which provided an 80% power to detect an overall treatment effect size of 0.2. This is equivalent to a mean difference in the Rowland-Morris disability score between the intervention and control groups of about 1. Standardized effect sizes and numbers needed to treat were calculated using a minimum of a 30% change in the Rowland-Morris scores. QALYs, or Quality Adjusted Life Years, were calculated with the EQ5D. More on QALYs in a moment. Here are examples of these stats and what numbers indicate regarding good or poor outcomes. We'll return to these later. For the Rowland-Morris, the minimal clinically important difference has been estimated at 2 to 5, and differences for those with mild disability 1 to 2, and 7 to 8 for high disability. You can also see the MCID for pain. This study evaluated projected cost savings using the general principle of cost utility. The objective of cost utility analysis is to evaluate the costs and consequences, which include benefits and potential complications, of using a health intervention in an effort to objectively apportion healthcare resources. QALYs were created to pull all health outcomes into the same frame of reference. There are numerous approaches to gauging a patient's value rating of the quality of their life. An example might be that a patient with diabetes and retinopathy would rate their quality of life as reduced by 35% or 0.65. Asking a sample of patients with the same health problems similar questions and pooling those answers gives an average QALY for that health state. A rating index called the EuroQol 5D system is the most commonly used. It's being utilized in many cost-effectiveness studies. The EQ5D is a 5-item system that quantifies 5 dimensions of health status, including mobility and walking, pain and discomfort, anxiety and depression, self-care, and usual activities. Individuals are asked to assess each dimension using a 3-level scale: basically no problem, some problems, and extreme problems. Additionally, patients are asked to rate their health using a visual analog scale of 0 to 100, with 100 as full health using a graphical thermometer. The EQ5D is then adjusted for the obvious, such as age, gender, race, ethnicity, and income. So in this study population, the START categorization created the following percentages by risk: 26% in the low-risk group, 46% in the medium-risk group, and 28% in the high-risk group. So let's now examine the START questionnaire and how it's used to categorize patients. It starts with a single question. Item number 1. Overall, how bothersome has your back pain been in the last 2 weeks? Patients' choices are not at all, slightly, moderately, very much, and extremely. Then items 2 through 9 are used as we see here. Psychosocial subscale items include item 1 and item 4, it's really not safe for a person with a condition like mine to be physically active. Item 7, worrying thoughts have been going through my mind a lot of the time over the last 2 weeks. Item 8, I feel that my back pain is terrible and that it's never going to get any better. And item 9, in general, in the last 2 weeks, I've not enjoyed all the things I used to enjoy. Patients are placed in the high-risk group if their psychosocial score is equal to or greater than 4. They're placed in the low-risk group if their overall score is less than 4. And they're placed in the medium-risk group if their overall score is equal to or greater than 4. Again, using the START classification for this study, 26% of patients were categorized as low risk, 46% for medium risk, and 28% for high risk. Now the results. Let's start with some key findings emphasized by the researchers. The mean number of total treatments was similar between both groups. Those in the intervention group who were referred had fewer physiotherapy sessions, but not by much. The reduction in the Rowland-Morris Disability Questionnaire was statistically significant in favor of the intervention group. The best results were most significant at 4 months and for the high-risk group. There are some clear pluses that are not debatable. One of these is that the lost workdays were fewer for the intervention group, especially for medium-risk patients, and that the patient satisfaction was higher in the intervention group compared to the control group. Some minuses that the researchers point out is that the difference between the high-risk group at 12 months was not significant and that the effect sizes were no better than previous studies. So, are there any cost savings? Well, that depends. Using a very indirect measure, the EQ5D scores and the QALY estimates, the mean healthcare cost was lower by about $53 US. Potentially significant, though, is that savings from the decrease in lost workdays in the intervention group was estimated at over $1,000, especially in the medium risk group. Now here's where it gets interesting. More low-risk patients in the control group, 49%, compared to the intervention group, 7%, were referred for an average of 5 additional physiotherapy sessions, so there's more cost with controlled decision-making. However, 40% of the medium risk and 32% of the high-risk patients in the control group were not referred for further sessions, so therefore less cost with control group decision-making. Given the high-risk group differences were not significant at 12 months, this would seem to demonstrate no advantage of referral for high-risk patients for psychosocial attention, which would indirectly imply the control group decisions, which is usual care, were more cost-effective. So how big a difference and advantage was there with stratification at 12-month follow-up? Not that impressive, with the effect sizes, numbers needed to treat, and mean differences not statistically strong, though the odds ratios and changes in Rowland-Morris Disability Questionnaire for a 30% change between the intervention group and control group were decent. But let's look at these more closely. Here's the major concern from a scientific perspective. When looking at individual group differences not averaged as above, many of the confidence intervals for the mean differences fall below 0, and many of the confidence intervals for odds ratios fall below 1. And many of the p-values do not indicate statistical significance. This study is not as strong as many seem to believe if looked at for specific between-group inspection, meaning for the low, medium, and high-risk groups, instead of averaging them together. Use this slide for comparison, but keep in mind these are what are called point estimates. The confidence intervals or ranges we just discussed should always stay above a threshold line of 0 for mean differences and 1 for odds ratios to be trustworthy. Here's a recent study also conducted in England, but in a chiropractic setting. Relationship between StartBack screening tool and prognosis for low back pain patients receiving spinal manipulative therapy by Field and Newell, published in Chiropractic and Manual Therapies in 2012. The general question is the StartBack approach applicable to a chiropractic patient population? The intention of the study was to see if patients categorized as high risk using the STAR tool would have different outcomes when treated chiropractically than patients in the low or medium risk groups. The proportion of high-risk patients that improved was not statistically different than patients categorized as medium risk. The STAR tool was initially able to discriminate based on the Bournemouth questionnaire and pain, the primary outcome measures, but lost that ability at 30 days due to a greater improvement in the high-risk group than proposed by the START tool. Note that 41% of patients had received chiropractic care from the same practitioner, so expectations may have played a role. Also, patients were followed only through 90 days. Some other differences proposed were that chiropractic patients may be inherently more psychologically healthy. Also, chiropractors may have introduced measures addressing psychological issues, such as fear avoidance and return to work, influencing the results. And measures used were different than the Hill et al. Study. So we're left with many questions. Should the results from the Hill et al. Study be generalized to the U.S., given it was conducted in the U.K. and used physiotherapists? Also, who's allowed to classify patients? Healthcare professionals such as MDs, chiropractors, or physiotherapists, or can other methods be used, such as a web-based tool, a nurse advice line, or a health advocate. When looking at how the high-risk patients were managed in the Hill et al. Study, it was physiotherapists, not specialists, who utilized the psychosocial approaches. In fact, physiotherapists managing the high-risk group had only 6 days of training beyond those managing the medium-risk group. So again, the question must be asked, are we talking about who manages the patient, or how much training and when to apply that training, specifically psychosocial approaches? So the biggest question yet to be answered is there a misinterpretation of the value of the StartBack approach? Studies upon which U.S. managed care groups are relying on do not indicate transferability to either the U.S. healthcare system or chiropractors, given these studies are from the UK and involve physiotherapists, and that a recent chiropractically based study indicates there is less value for using the START categorization in the context of chiropractic patient decision-making.